Okay, that's not a huge volume compared to the commercial agencies, but it's still a lot of cost. And lots of times, ALS is not available from our providers or from CMT. Okay, you got a patient seizing and we don't have ALS, okay, or we don't have CMT coming in and we have ALS. If we apply for a controlled substance plan and get the controlled substance on board, at least we'd be able to administer some medication. But I think it's shooting the rural providers right in the foot if you're going to do that. I really do.
Well, when you think about the issue of capnography, which came out, I think, in an advisory saying that it was a standard of care, I don't know how the discussion will go in January, but I suspect it will be something said about maybe making this an advisory and creating it as a standard of care, and then squads have to look at that and think about, that's a big push to do it, but it isn't mandatory, except that you have to think that if you get in a jam with a bad patient and end up in court, and you're not meeting the standard of care, so that's what you have to think about.
I would be very careful about using the term standard of care. I mean, I don't think standards of care are uniform geographically across New York. Response times are definitely not uniform across the state of New York.
Right.
I think that the CC and paramedic curriculum are uniform throughout the state of New York, and that, to me, should be based off of a standard of care.
Well, I mean, maybe, but you're getting to the practical level of implementation, and I would say in a vacuum of data. You know, from a medical standpoint, you can say, this person has pain, we must give pain medication. Maybe. Good. That's me, yeah. Seizures, you know, how many patients have de novo seizures? I bet you 80% of cases of people who have known seizure disorders, the breakthrough seizures, they have medication in their house. Somebody in their house has that medication.
Yeah.
So I think we don't know the frequency of utilization of these drugs. I don't think the state is tracking this. I mean, maybe in a new database. You know, if you upload all the PCRs and you upload all the ALS data that's available out there, you may have to have a better handle on what is actually going on. How often are these drugs being utilized? How often are seizure drugs being utilized? What is the response time to seizure patients? How many of them are seizing actively when they get there? How long do they seize en route to a hospital? We have squads now that won't call ALS for a seizure patient because they don't like the other squad.
Wow.
And so you already have squads that are deciding to bypass available benzodiazepines for political reasons. So I would be leery about expanding a practice when we don't know the quality and the frequency of the current practice.
Good point.
So, you know, Daley's always sort of pushing the envelope on, but urban areas, if you look at an urban area, they're very different. I mean, they have standards on response time. You have 8 minutes to get there in the city of Manhattan.
Yeah.
You know, so try that. That's a standard of care. That's probably the most important standard of care, actually. How long till we get there?
Yeah.
So we don't have. We're trying to make a decision about something you can do. You know, must you do it? I would say, show me the data. Where's the data? Prove it. How many seizure patients are there?
Yeah.
And how many of them don't have medication in their house that couldn't be given? Like most pediatric patients with seizure disorders, their mom has that stuff. They've already given it before you get there, and it's usually stopped by the time you get there.
You know, I can appreciate your argument on seizures, but I got to tell you, almost every patient we transport has probably got pain.
Yeah.
Right. So is pain going to kill you?
Well, it is about a service that's supposed to be providing a humane service.
Right. Are there other ways to skin the cat? Yeah.
So do we take ALS assistance to a cardiac patient away from them because of that pain? To another patient? I've got
Diminishing ALS response?
Right, by saying, okay, you're no longer an ALS agency secondary to your
But I appreciate some of the arguments going around, for example, the private vehicle thing. Well, you know, there is agencies in New York State that have narcotics in their private vehicle. They're called Hot Zola. So these things are not insurmountable. So you really, it's true. And so it's a question about looking at, I agree with Dr. Leinhardt, looking at the whole picture and coming up with a well thought out
The
response.
configuration of EMS in the state of New York is different than other states. Other
Right.
states don't do it like this. Other states say all ALS is hospital-based, all of it. You don't run ALS unless you're associated with a hospital. And then maybe commercial superimposed on that system. So there's other ways of doing it. All I'm saying is, a lot of times we get sort of oriented towards the protocol, and nobody's doing any QI, PI, investigation of what actually is going on. Yeah, we can do this. You know, yeah, we can probably do, burr holes. Sure. What's the frequency? How often is it going to be done? Is it being done? Are narcotics currently being I'm kind of, when I hear the state saying, the documentation now is somewhat sketchy. Do you want to expand this? If the state isn't doing, if the agencies now, I think that's what she was implying, if the agencies now are kind of like substandard in terms of their own documentation, there's something they really want to take on, across the board. So I think the state does have a voice in saying, you know what, if you guys have, read a better foundation to expand it, you might consider it. But so you're basically talking pain and seizures. That's it. What else is in this world? I mean, those are two things you're talking about. It's not about the drugs. It's about the conditions. So how often is seizure medication being administered and for who? And are they actively seizing? Because to me, that's more important than pain. Pain is actually a survival mechanism. Jacks up your sympathetic nervous system and your blood pressure. Probably enables survival. Seizure is prolonged, actually kills your brain. So if I had to stagger those two, I'd say give me benzos on the regular before I give me narcotics.
So you get some idea of what the conversation might be like in January when this comes up.
So you got a lot of information now.
So Mark,
yeah.
that was one of the questions I had about the CMAC that I could not attend. What was the brouhaha about the Central New York Collaborative Protocol? Why was that so
There were.
vociferous?
I know.
Related?
I know.
Go ahead, Beth. No?
I know one of the things was that the physical layout was identical to
Oh, that
ours.
was it? It was a
Yeah,
format
right.
issue?
That
That
was
the
the big
format, that the
problem.
stop lines for each color were identical to ours. And they did not want a medic who works in both regions to be confused going from one book to the other with exactly identical looking formats.
The protocols themselves are very different.
No, that's what. So
Right.
what was the content difference about it?
The content, I can't tell you. The physical layout I caught.
I know STEMI,
There was
STEMI and ACS was a big topic.
Right, there was a discussion about whether or not they should include consideration of air transport within an hour, and there was
For STEMI?
For STEMI.
Right.
That was a big topic because they really don't have a STEMI protocol. It all fits into like one ACS protocol, and the way they wanted it to word was if the patient's having chest pain, you automatically get a helicopter ride. If you were to a STEMI center, you couldn't make it there in an hour.
yeah, there was a long discussion about
Just for chest pain?
dosing should be a dosing range rather than a specific dose, and there was some discussion about RSI versus medically facilitated intubation. So
Just
it was,
link, so the air flight and what other?
MFI and RSI, with what should they be doing? RSI, MFI.
What we call it? That's
Not even what they call
They
it.
have two separate protocols. They've had a long-standing tradition of over 20 years of using etomidate for induction for intubation. But they don't have a full RSI protocol.
Where is this?
And they're satisfied with what they've had because they've got 20 years of good practice experience with it with very few medical interventions.
You mean standard of care?
Standard of care for that region, that's what you'll be held to in a court of law during your
Right,
peers.
but what I'm saying is, would it be state standard of care?
There is no such thing as a state standard of
Okay,
care.
but CMAC.
Or
that's-
state ALS protocol.
Yeah.
Or a state ALS protocol.
Right, but it meets the minimum state ALS requirements, right? Those all
I'm
have
glad
to
I
be
brought
published.
this all up for you.
We've given you something to think about.
We're still in the middle of my report. Cheryl Mayer is the chair of the Finance Committee, and she's pretty feisty. And she submitted, we approved a $23 million budget, which we've approved other years. And she was not going to downsize it, even though in previous years we've been allocated $18 or $19 million out of the 23. But she is emphasizing in her report to the commissioner that there hasn't been any cost of living allowances for 7 or 8 years now. And I wanted to give Phil and Joyce a heads up that next year they're going to start working on the budget in January. And there's going to be an early template out so that we can get this budget request in much earlier than it's required by December. So we approve it now in September, and it goes through the commissioner and eventually gets to the governor's office. That's really too late. And that may be one of the reasons why we don't get as much money as we really ought to. So they're going to start very early next year on the whole budget process. So heads up.
Great. Howard, just let the record show I was innocent on this one.
Yeah, right.
Take 3 minutes to move all the glasses away from them.
Under systems, committee that I chair, I've included Mike Taylor's list of 20-some CON things in process. Dana Jonas spoke about narrow banding, and there is and I've included this, this is the sheet that he passed out. There is a map on this website where you can mouse over these little needles here and pins and find out what the frequency is, I guess what the agency is, and whether or not they're narrow banded. So you can do that for your own counties.
Those are transmitter locations, Mark.
Yeah.
So it depends on where your transmitter is. So like with you guys, it should show dots for you on Maridale, Utsey, and
Right. Right.
it won't show the actual physical location of your radio.
Right. But anyway, I guess that's a pretty interesting site, so you can go to it and you can figure out whether your hospitals are narrow banded or whether you are or your neighbors are. And I hasten to point out that those of us who have 155.715 in our radios, it's no longer an interoperative frequency. The state police is using it a lot. If you have it, you can still continue to use it, but 155.340 is now designated as the national and state interoperational frequency. Okay?
Now, neither of those are narrow band as they currently stand. They're going to be narrow banded.
Oh, they should be, yeah.
They'd have to be, in other words, all scanners and transmitters would have to be reprogrammed.
Yeah, right.
Was that a topic of discussion, or was that that's the way it is?
That's the way it is.
Oh, because one of the issues that I would have with that, only because you're in a helicopter, you're at 3,000 feet, and right now we use 155.715 for a lot of the local agencies.
Uh-huh.
If we went to 340, we'd never hear them because the hospitals just blast us. We get absolutely blasted by the hospitals on 340. We can't
Yeah,
even call
the
Patrick
helicopters
Boats.
have their own, that was
Yeah,
a discussion.
there is-
Yeah,
right.
the UHF, but that's our own, but that's not for a ground
Channel
contact.
92 or something.
Yeah, but it's not for an ambulance to contact us, or for an
UHF
LZ operation.
frequencies are notoriously unreliable for ground use
Yeah.
in rural areas,
Absolutely.
Right,
mountainous areas.
because
They're
it's so
completely
line of sight
unreliable.
because the frequency is so
Absolutely.
high.
They're best in urban areas by far.
You gotta
They go
do
right
it
through
by
concrete, but they
repeating.
won't go through a tree.
But when
Well, that's an
we're-
interesting question. I would suggest maybe you call Dana Jones and talk to him about it.
Yeah, because
Have a lot of time.
Huh? Oh, I know, I talked to him
Yeah.
numerous times.
Is that right?
But the minute you switch over, and I'm just speaking from personal use, you switch to 340 to even give report to Bassett Hospital if we're coming into Bassett, you can't do it. Wilson is blasting you.
It was pretty clear,
Syracuse.
if you're using 715, you can still use it.
Yeah, but I'm just saying, as they put that out there to the ground agencies, they're gonna switch over to 340 and want us to try to do the same thing, and
Right.
you just can't do it.
Okay, very interesting. The PCR database is up and running. They're uploading data to it. They got about a million PCRs in, I guess. Martha wanted everybody to understand that there is no list of approved ePCR vendors, and not all vendors are NEMSIS compliant. So you can check with her, or you can check the NEMSIS website to find out. I have appointed a tag to look at the new NFPA ambulance standards, which are 81 pages. If anybody wants to look at this, I'll pass it around.
You paid $12.95 to download it?
Yeah, right. No, I did not. If you Google NFPA 1917 draft, you can just print it out. So I found out. So I have 4 people on this tag, and we haven't met yet, but we're going to. And Mike McAvoy was on the committee who wrote this, and I had a phone conference yesterday with my ambulance dealer in Syracuse, who was just back from a 4-day conference in Indiana with Braun ambulance folks, and they were talking about the new standards. And I have been led to believe that a lot of the manufacturers are going to the new standard. That may not be entirely true, because this standard is still a draft and is scheduled to be approved in 2015. So a lot of the manufacturers are saying, I don't know how we can build to this because it's still a draft and there's going to be changes to it. And but I wanted to point out that that was a sort of a caveat to what I'd said in the report. And then Lee said that she's had some inquiries from services who are considering new ambulances, and one of the big changes in the standard is that you're only required to carry 1 patient in the back of the ambulance. It says nothing about carrying a second recumbent patient, which Part 800 does. But if you write a letter to the department and explain how you're going to deal with carrying a second patient, either you have a second ambulance that you're going to get to the scene, or you're going to call somebody else, or you're going to make some other arrangement. You're going to borrow a grocery cart from the Price Chopper or something. They will write you a waiver. My sense from this conversation yesterday is that although this standard's scheduled to go into, it's supposed to be in effect now, but it won't be finally approved until 2015. But there's going to be a 2 or 3 year grace period about all of this with regard to the manufacturers. And the back, of course, is Mike McAvoy's notes from the council meeting as well, which are intentionally amusing.
Mark, can you elaborate on the tag Mr. Kroll is going to head up for community paramedicine?
Yeah, Mohawk Ambulance had a proposal, a community paramedicine proposal to provide flu vaccinations. So they did a little study of about 2,000 patients that they had actually picked up, and they inquired of these patients whether or not they'd been able to get a flu shot. And I think it was like 60% of them said they had not. So they wanted to do a pilot program, pilot project, to provide flu vaccination to these patients, I believe. I don't think they were going to set up Rich, maybe you can comment on that. They weren't going to set up a whole flu clinic.
So those patients that they already had contact with for
Right.
other reasons.
And they notified the department at one of our meetings, and the department came back, and they went to the DLA folks, and they said that's outside your scope of practice, you cannot do that.
But to that, and this is what, remember years ago, you spoke about, they just got done with a federal meeting of stakeholders sponsored by NHTSA to put together a nationwide community paramedic concept that included a lot of the things that you had discussed, paramedics doing well visits, paramedic doing post-discharge visits and so forth and so on. This is happening across the country and is being funded by the Department of Health and Human Services to the tune of grants of $5 billion with a B dollars. So they're taking this very seriously.
Yeah,
So you
expanded scope paramedic practice.
expanded scope. So you can see this is coming down the road, and sure there'll have to be changes in legislation to permit paramedics to practice outside of that Part 800 and Article 30, but it's in the future. You predicted it years ago, and that's what's coming down the pike.
And there's an effort in New York City that I think is going to band with this tag to some extent.
You're doing some of that down there now.
I have been volunteered by Rich Brandt to be on the tag.
And if you're interested, there's a website called Community Paramedic, and it describes all of this on that website as part of, it's the NHTSA site, it's Community Paramedic.
Yeah, this is, an idea like this was brought up a few years ago also when paramedics giving their agency members their hepatitis shots. Not the paramedic scope of practice, so they weren't allowed to do it.
That's why we have a nurse.
That's why we have a
Get
nurse.
orders from a physician to give them.
Right.
Right. But I mean, post 9/11, there was a lot of discussion about what would we do if,
Yeah.
and that was swine flu or, bird flu.
Well, at the moment, you get a special dispensation for a certain period of time from the commissioner, but that's really not adequate.
Only in an epidemic.
Yeah.
Only in an epidemic and only
Pandemic.
after completing a 6-hour
Right.
department sanctioned course.
Right, public health and everything.
For very specific vaccinations,
Correct.
Right,
smallpox.
and a specific event.
I think the conversation was triggered by Dr. Funk's proposal to do
That's
flu
right.
vaccines in the ambulance, but it's part of a bigger conversation that's going on nationally and internationally.
And I think Lee is in favor of this. I mean, she said that this is not the end of the story in terms of the Mohawk situation, so we'll see how that goes. Anybody else got any questions?
Mark, with the image trend stuff,
Yeah.
at some point, the agencies will be able to get access to that image trend?
That's right, yeah, I wanted to point that out,
Access to
that those agencies who are going to stay on paper PCRs can acquire an account. Their PCRs will be entered into the system, and they can get an account to look at their data. Okay?
I called Steve the other day.
No time frame
in regards to that.
I don't.
I don't think they're giving out accounts yet.
They may not yet, but it's
As of
pretty
the
clear
other day
that
when I
that's
spoke
the...
with Steve, he said, don't worry about it. He said most of the providers, even though they're NEMSIS compliant, because they're already providing the service in New York, are still not able to upload in the XML format in which Image Trend wants to do without some sort of change. So until, and our
Right.
software vendor in particular said until they're notified by the state, they have no intention, while it's an easy change, they have no intention of changing it until the state notifies them.
So I think it's not available at the moment, but I think it will be. I think that's the intent.
When the 3 standard comes out, whatever, NEMSIS 3, what do they call it? We're at 2.0 or something right now. That's when supposedly New York State is looking to change over to Image.
And I would hasten to point out that my alternate, Tom, was there for both days, the committee day and the systems committee in the morning and the regular meeting in the afternoon. And I think he learned a lot.
It was interesting.
It is very interesting up there, isn't it?
Hey, Tom, who did you say, which one of the electronic PCR providers declared bankruptcy?
Oh, that was this morning, I heard Ruth was saying that, EMS charts.
Oh, EMS charts, okay.
Really?
Declare bankruptcy.
Yes,
Yeah. I thought it was you that said it.
they're not going out of business.
No, Rich Ruth has said it's
Okay.
Protection.
That's the end of my report. I'm glad you all enjoyed the cartoons.
That's another question.
Just-
Mary was out of the room when we were having a tirade about
Sorry,
controlled
I'm
substance. Does Image Trend capture utilization of narcotics, administration of narcotics for
Beth can answer that.
benzodiazepines or etomidate or any other of the ALS drugs? Is that part of the Image Trend database? It
Yes.
is. Okay, so can
Any,
Remax
whatever
get-
drugs you load in there are captured. Right now, ours is configured to have all of the medications that are in our formulary. We also have a method of entering, say for a specialty care transport, we're issued something, we have a way of capturing that as well.
So the database can be analyzed for those uses of drugs.
Right.
One of the things I was asking is how often are seizure medications offered?
Well, what I was going to say is I think once this database is up and running in a year or two, and with the ease of electronic access, I think some of your questions can probably be answered.
The question is whether or not it's a reportable data point. Not whether or not it's collected, whether or not it's a reportable data point that goes up to the state platform. There's only, right now, there are only 125 reportable data points.
Right.
And you can see those on the DOH website, so I don't have an answer for your
Where you
question.
can get the information, I'm sorry.
If I remember correctly, though, as far as medication use, one of the reportable data point does not have the particular medication.
You said medication
It's
issues
just
were used.
medication.
But what you can do is Phil, as the administrator for the region, would have access to all the ePCR accounts, because that was one of the things when they assign on as an ePCR for whatever program they're using, the regional program has to have access to it.
Right.
Phil could go in as the administrator and run a query, chief complaint of seizures, drug use, and pull up side by side what was given,
But only for those agencies.
that are using ePCRs. Otherwise, it'll be the Joyce, Hunt, and Peck through every PCR method.
But that isn't the case. We didn't have to say that Phil would have access to our ePCRs. We would supply the region in some way, shape, or form with that information.
Yeah, right.
Right, it goes in,
Usually your vendor sets up
Right.
something with your program agency,
Yeah.
right? You're
Depending.
using-
It depends, I mean, they
It
haven't
depends.
brought that up at all.
It's not a requirement that they
Okay.
access to our system. It's a requirement that they get the information that the region puts forth.
I believe that it only says that and I don't have the standard in front of me, I could find it, but the requirement is that it gets uploaded to the state. And I don't believe it says anything about region.
I think you're.
It depends on how it's
set.
set up. It depends on the volume of calls, how it's set up, is what it is. You two are larger commercial services, so you may bypass. But so an agency that does 500 calls a year would probably have Phil on as an administrator and go that way.
Maybe, yeah.
So if somebody wanted to ask the state of New York, so tell me about benzodiazepines. When this thing is full blown, and you have a state repository with either paper converted to electronic or ePCRs direct, is that an element in that database?
I do not know the answer to that. That would be a Martha Golke question because she deals directly with that vendor.
And
We're
that-
still learning it.
Again, that depends on whether she puts in medication used or what particular medication was used.
Yeah, medication
You can
use
have-
is useless.
Right, I know, but that depends on how they record that
Right,
in their data point.
so we may never know.
But on the other hand, I think you could go to us or Tom, and we could run a query of our own data.
Right.
Yeah, but this bigger question, when you're talking about, putting controlled substances on every ALS limit,
Right.
that begs the question, so where does that data go? You guys are already there, but where does the rest of this data upload?
Well, I understand, but you'd get some data, and then you could go from there, but,
The only question would be for you, I guess, you're not like urban, or, you're a rural agency.
Most of them
where,
can.
we've got cities and towns.
Right, the proximity to the hospital.
Right, so you're not in that rural setting.
You could query the dispatch centers that use the MD and see how many calls are dispatched as seizures, where the potential would be.
right, yeah.
The
Sounds like a program
EMS
deliverable to me.
The electronic PCR data submission policy says that such rules shall be defined, the data elements to be submitted, and may include requirements that assure availability of data to the Regional Emergency Medical Advisory Committee. So this group, or the REMAC, would have to put some sort of requirement in for the data to go to the region.
Well, right now, any ePCR agency in our region, to get our permission, has to agree that they will make data available to us upon our request. Right.
Okay. One last question is this last cartoon about the cloud. Can we use that with the state?
The cloud ate my data?
The cloud ate my homework.
That's a legitimate excuse.
It is, no question.
Well, there was another cartoon that I didn't put in here, but it was a funeral situation, and two parents are walking along with this little kid, and they said, "Papa's in the cloud now."
Instead of the cloud, we can say the Chinese ate my data.
And I gotta
North
tell you,
Koreans,
this is not anything to do with EMS, but I got this very funny video this morning from a friend of mine in Canada that is possibly the stupidest woman on the planet. It says, conversation with a radio talk host. And this lady calls up and says, "You know, I've had 3 accidents with deer in deer crossing zones. Now, why doesn't the state put deer crossing zones in areas that are low traffic instead of high traffic? Put them outside of small towns or wherever, so the deer know that they can cross there instead of places that are high traffic."
Excellent
And she
thought.
was entirely serious about this. Went on for about 5 minutes.
Well, maybe Mary and Joe can look into that for us.
It's just incredible.
We just want to say, here's your sign, you know?
She said you could put them in, how about school crossings? You know, that would work pretty well, because there's a lot of kids going across, they could go across too.
You never underestimate.
You never go broke underestimating people.
Okay.
Just as an aside, Lou, I just wanted to tell you back to the narcotics thing, and in the 1980s, and that's going back some, but the only way you could carry narcotics was to be appointed a hospital-based ambulance for the purpose of carrying narcotics.
Right.
That's the only way you could do
And
it.
that was most assuredly blessed by the state. It was a matter of
Absolutely.
state legislation at the time. Yeah.
It's one way of guaranteeing the pharmacist.
Yeah.
That's right.
There you
Yep. And we did that for many, many
go.
years
Over many years, yeah.
as a hospital-based ambulance.
Okay, moving right along. Thank you, Mark. Anything on the regional program update?
Nothing to report there.
Okay, any other program updates?
Nothing to report.
Do you have anything from everything? Okay, county reports, Delaware?
Business as usual. We have an EMT class in Sydney going on with 15, I think. We started one last night in Delhi with 27 originals and a handful of refreshers.
Excellent.
Otsego?
Business as usual. Again, a good-sized new class going on, and a research as well, 2 new classes.
Okay, Schoharie? Anybody here from Schoharie?
Nobody here today.
Montgomery?
All is quiet, we haven't had our meeting. Us as an agency, we are exploring the option and working with Phil and Joyce and Speculator to run an EMT original and EMT refresher course at our facility, I think in March. So we're in the process of doing that to determine on whether or not it's beneficial for us to apply as a training site for the state. There have been several departments around us that have expressed the need because of the lack of courses in our particular area, mainly Montgomery, Fulton, and Hamilton counties, the lack of refresher courses and certification courses. So that's something that we're
Well,
looking
this has been since Amsterdam Memorial's core sponsorship
Right.
folded with the merger of the 2 hospitals.
Right.
So they're looking not necessarily to add, but just to replace a previously
replace.
existing.
Okay. Oh, Fulton?
Nothing new.
Nothing new, okay. Hamilton?
Hamilton is struggling, like everybody else, with daytime coverage. There's been a lot of discussion, no action. And we're currently working with an agency also that we don't really know what's going to happen with them, but it's a very, very small agency, and whether they're going to become a first responder agency or become part of another agency or whatever, but they're having some internal problems, so we're working with them.
Okay. Thank you. Any other business for this council? No? I think we got a letter from a certain person that doesn't want to see us the rest of the winter. So we'll wish Jack a safe, happy trip.
Oh, he's leaving?
I'm leaving, yes, it's cold.
Okay. Motion for adjournment?
We next meet on November 15th. It will be preceded by a REMAC at 10:30 that morning.
Hey, Mayor. By the way, I knew I talked to at least three had to go away, so she's going to get